I'd like to talk about some ACS myths here. Some statements that you hear as facts of life, and actually, if you think about them, if you investigate them further, you discover that there is actually no science behind this to support them. They are kind of myths. They are kind of false fixed beliefs, delusions by definitions, if you see what I mean. So let's go through some statements and let's see, what do you think about these? Did you hear about these things from people before as facts of life? Let's go through some. So we've seen this before when we talked about pericarditis, but let's just revisit them again because they worth revisiting. So if the ST elevation is saddle shape, it is pericarditis. It cannot be a STEMI. We know now that this is wrong. Yes, pericarditis will cause ST elevation that is saddle shape, but STEMI can also cause ST elevation that is saddle shape. So having a saddle shape ST elevation does not equal all the time acute pericarditis. So if the ST elevation is diffuse, non-anatomical, it cannot be a STEMI. We know now that this is actually wrong. We've seen with the wraparound LAD lesions that you get ST elevation in most of the leads. And we've also seen this in the case of Kunis syndrome, where there was an occlusion of the RCA and the left and the LAD in the same time because of the syndrome. So it is possible to see a diffuse ST elevation, and it is at the end of the day a STEMI rather than pericarditis. So pericarditis causes ST elevation that is always diffuse. So if it is localized, it cannot be pericarditis. Well, actually, no. Pericarditis ST elevation can be localized. So this is wrong, but it is not that common. So the commonest is that you will see diffuse ST elevation in case of pericarditis, but if it is localized, that does not mean it's impossible for this to be pericarditis. It can be localized. So only pericarditis can cause PR depression with the ST elevation, and actually this is proven wrong. We've seen through the course some ECG cases where there was PR depression with ST elevation and it was proven to be STEMI. So do not assume because you see PR depression, and by the way, same PR elevation in AVR, when you see these, do not assume that only pericarditis can cause this. These are not pathognomonic for pericarditis. They can happen with STEMI as well. So let's move on and talk about some STEMI or some ACS, let's say, myths or statements that are believed to be true for some reason. So you can get localized ischemia, like ST depression in inferior leads only, for example, without elevation anywhere else. So do you think that this is true or wrong? Can you get localized ischemia? Can ischemia localize? No. When you see localized ischemia, think about an ST elevation somewhere that you cannot see. You cannot really see. So ischemia doesn't localize, basically. Infarction does, ischemia doesn't. So when you see ST elevation, ST depression in 2-3 AVF only, probably there is an ST elevation in the lateral leads that you cannot really see. When you see ST depression in 1 AVL, V5 and V6, probably there is an ST elevation in the inferior leads that you cannot see. If it is just ischemia, the depression will be diffuse. It's not going to be localized to a single wall. So again, ischemia doesn't localize, infarction does. Next is, so new or presumed new left bundle branch block per se is an indication for immediate PCI activation. Do you think this is true? Well, we've talked about this in length and we now know that this is wrong. So just having left bundle branch block is not an indication for PCI activation. You have to have something else with it so you can qualify for immediate cath lab activation. You cannot really assess the ST elevation in presence of left bundle branch block or in paced rhythm. So I hear this all the time because left bundle can cause ST elevation per se, and the paced rhythm can cause ST elevation. So actually, how can you tell that this elevation is because of a STEMI or because of the left bundle or the paced rhythm? Again, we've covered this in details, and we know now that this is wrong, and you can actually assess the ST elevation in presence of left bundle or in a paced rhythm using the Scarboza criteria and the Smith rule and some other signs that can help you to diagnose STEMI in presence of bundle branch block and in paced rhythm. And lastly, immediate PCI is for STEMIs only. Do you agree with this? Well, actually, no. We've just seen some other indications for immediate PCI that does not include STEMI there. So you can activate the cath lab immediately for non-STEMIs if they are hemodynamically unstable or electrically unstable, or if their pain is not responding to medical treatment.